Okay, welcome everyone to this webinar this evening from VET.CT. I'm very pleased to be able to introduce Dr. Elsa Beltran, who's going to be speaking to you tonight. But first of all, for those of you who don't know me, my name's Kate Murphy. I'm one of the internal medicine consultants at VET.CT and also head of teleconsulting clinical services. So what we're going to do this evening is have a webinar from Elsa about assessing and managing the patient that's off its back legs. But just to introduce VET.CT to you, for any of you who don't know us already, we can change the slide, Elsa. So VET.CT has over 200 specialists working globally. So it means that we're able to provide support round the clock all year round. And we have sort of three main streams to what we do at VET.CT. We have the radiology service, which provides amazing reports, very highly detailed and helpful to support you with managing your cases. And that's in sort of radiography, CT and MRI. We also have the team of teleconsultants who are around to help provide specialist advice. And what we will offer with that is written case advice within 12 to 24 hours and often sooner. But in some of our specialties like neurology, which Elsa works in, internal medicine, which I work in, orthopedics and oncology, you can also have phone conversations with us or text chats. And what you'll always get is a detailed written report that will come into your platform that you can share with your colleagues and with your clients so that you have a nice summary of where to go next. So if you haven't used us before, please feel free to take a look. We're here to help basically with that. If you want to get a demonstration of it, we can go to the next slide, Elsa, and you can reach out to me or scan the QR code there to get some more information on the teleconsulting service. So this session is recorded. And we will be able to take questions at the end through the chat function. So if you want to put any questions into chat, that's absolutely fine. And we are just to keep muted so that we can hear Elsa telling us about assessing the dog that's off its back legs. Now, Elsa is probably known to many of you. She's an amazing neurologist who works with us at VET.CT, also works at the Royal Veterinary College at the University of London, and has an amazing educational experience and is just incredibly energetic and clear at helping us to understand neurology, which is an area I've always found a little confusing. So over to you, Elsa.
Thank you so much, Katie, for the introduction. So welcome everyone to this seminar. What we're going to do during this lecture is try to talk about what is the most important thing when we evaluate patients that come. I'm not really a fan of this name, off the back legs, because I think we should avoid writing this in our reports or when we describe a case, because that probably describe a wide variety of the different degrees of conditions that can cause myelopathy, or it could be something that is a bilateral cruciate, and there are different conditions. So it's important that we get used to apply the terminology that if someone else read it, can understand what we think is happening. So when we talk about what are the dilemmas that sometimes we ask ourselves when we have patients that come with a degree of myelopathy, and this is, I'm going to explain you the word that we're going to use, but the first question, if you have a patient that comes and is not able to use the back legs properly, and this is probably the term that we apply when we want to say off the back legs, so it's not using the pelvic links properly. The first question, is it neurological? Because sometimes it's not so easy to answer that question. If we have different differentials, we have an intervertebral disc herniation, we have a ischemic myelopathy, a vascular event, how can I tell, or what is the most likely clinical presentation when I have these, for instance, differentials? Then some questions, or sometimes we ask ourselves, is something that we can wait and see? Is something that is definitely a case that will benefit from a surgical decompression? And we're going to talk about that, because if we know that there is a likelihood, very likely, that that patient, that cat or that dog is not going to require surgery, then we can potentially wait and see, because if it's something like an ischemic myelopathy, one intervertebral disc that is not compressive, it may get better on conservative management and physiotherapy. Then what is the clinical prognosis, or what is the prognosis of that patient? Can I say it just evaluating the clinical signs? And sometimes we can, and we're going to explain some of the clinical signs where can tell us about prognosis. And then, why do I tell the client if we cannot afford a referral for surgery? We from VET.CT can help you to decide what will be the clinical management that we can do from distance and see the progression of that patient, evaluate the dog day by day to see if we a clinical response that tell us that may not be a case that 100% needs to go for a referral center. And then the question on the clinical management, what happened with the steroids? No, are they needed? Are they not needed? It depends. It really depends on the underlying cause. So we're going to see clinical cases during this lecture, but one thing that in myelopathies, in spinal cord diseases that give us clinical signs that our patients are not able to use the pelvic limbs, is really important that we apply the clinical reason in general to any patient, but in neurology and specifically for myelopathies, what it works really well is what is known as the 5-finger rule. This is a way to remember all the information that is really important to help us to list our list of differentials. And then from there, when we have the most likely to the less likely differentials, then we can think about a diagnostic plan. So what is really important always is the signal, man. If you call me and you say, oh, Elsa, can you help me? I have this dog that is off the back legs, obviously. What we are going to discuss, okay, what is the signal, man? When did it start? Is an acute, is peracute, is chronic? How is the clinical course? Is getting worse? Is getting better, while this is not getting worse, and it happened yesterday. Is waxing and waning, or is episodic? What we're seeing problems with the pelvic limbs is episodic, and between those episodes, the dog is totally normal or the cat is totally normal. Is there any signs of lateralization, like it's extremely lateralized? You tell me, oh, yes, the right pelvic limb is plegic, so it cannot move it at all, but the left is totally normal. That really helps us a lot if you have a condition that is extremely lateralized. Then, do you think it's painful? That's also really important because the spinal cord itself does not have receptor for pain, which means if you have a condition that just affects the spinal cord, it doesn't affect the meninges, that condition should not be painful unless it's growing and overstretching the meninges, or it's a condition that is coming from outside and is compressing or arising from the meninges, that potentially can cause pain. But the spinal cord does not have receptor for pain. And then what is the neuroanatomical localization? Here, we're going to talk about conditions that affect the spinal cord. So remember that if we have the neuro-localization, the spinal cord is divided in spinal cord segments. And we're going to talk about that later, but we're going to focus on T3, L3 myelopathies or L4, S3 myelopathies. And then with all of that, we're going to be able to make a list of differentials if we obviously apply our clinical experience. No, the longer we're seeing patients, the years since we graduate, it's going to give us a lot of clinical experience, but that's not enough. We have to get knowledge. This is why we are here. This is what we continue to read. This is what we continue to go to conferences, because that increases our medical knowledge, and then we reflect. And it's really important to reflect about the cases that, for instance, they didn't go well. Why was not going well? Was something that I did or could have done different? And did I learn something from that case? And that is going to make us much better as veterinary surgeons. And applying this, at least at the beginning, we're going to try to make sure that we get to etiological diagnosis, like is inflammatory, infectious, and then depending on the country that we are, the part of the world that we are, so we can say, yes, in this country, this infectious is very high, or could be something immunomediated. Are we talking about something that started peracute, is static, or is slightly better? To be honest, there are very few things that can do that. So it could be vascular, it could be a contusion to the spinal cord. So those are conditions that we know they have a peracute onset, and they may start getting better within a few hours or days after the onset. So when we talk about of its back legs, as we said before, it's hard to say if you write that on the referral letter. What do you mean exactly? In the meaning, sometimes it's not so easy to say, okay, I'm sure there are neurological deficits, and then we're going to talk about possible myelopathy. So that will be giving us more information, or you can say, look, I think there is something with the bones or with the joints, and I think it looks more like an orthopedic condition that it is not allowing the patient to work properly. So we're talking about myelopathy, which obviously means a condition that is affecting the spinal cord. We will have to divide within the spinal cord segments, as we said. So the first group of spinal cord segments, which means if I have a lesion at any point there, clinically, is going to give me the same clinical signs, which means I'm not able to differentiate between a lesion affected C3, C4 spinal cord segments or C4, C5 spinal cord segments, because clinically I'm going to see the same. So that will be the first group of spinal cord segments, will be C1, C5, and that will affect likely either one side or all four limbs. If I have a lesion of C62, the same, either one side if it's really unilateral or all four. So we're not going to talk about cervical or cervicothoracic lesion. We're going to focus on conditions that affect the pelvic limb. So if we have a lesion between the T3, between T3 and L3 spinal cord segments, we're going to have particular clinical signs. If we have a lesion that affects the intumescence at the level of the L4-S3, then we also will see particular clinical signs of the lower motor neuron that affect the pelvic limb. So as we said, we will see clinical signs that are going to help us to differentiate. You have to remember that when we talk about the myelopathy, important things, let's try to recognize what are the clinical signs that tell me there is a lesion in the spinal cord. And as we said, we try to localize between T3L3 or L4S3, because if we, for instance, do advanced imaging and you have very common, you have a French bulldog, you see the lumbosacral lesion is a disaster, is extremely compressed, the lumbosacral intervertebral disc, stenosis at that level, but the dog has a T3L3 neuro-localizations. I don't care about the lumbosacral because that dog is not having any clinical signs associated to that at that point. And then sometimes we ask ourselves, oh, should I be worried, as we said, or something that we should refer, something that potentially we can manage here. And then remember that when we neurolocalize, we do not neurolocalize on the vertebrae. We localize in the spinal cord segments, and they don't fully correlate at the same level where we have the vertebrae, because the spinal cord ends before the vertebrae. So pretty much when we talk about the level of L3 spinal cord segment, this we're talking pretty much around L1, L2, and then caudal to that is when we start our L4 S3 spinal cord segments. And for instance, the S3 spinal cord segments can end at the level of L5, L6 vertebra. So taking the history from your patient, as we said before, general history, and you are very good taking that from specifically neurology, what we want to ask, okay, what happened with those clinical signs that are affecting the pelvic limbs? When did it start? How was the onset? Do you think it was acute, peracute, which means within 24, 48 hours? Do you think it has been going on for days, weeks, months? Obviously, that's also important because chronic can be days, can be weeks, or can be months. So it's very important to specify. Then for how long has been going on? Yes, has been acute 2 weeks ago, but over the last 2 weeks is pretty much the same, or over the last 2 weeks has been getting worse. As we said, is it getting worse? Is it getting better? Or is episodic? Is not happening all the time? And as we said, the lateralization also very important when we want to list our differentials. And as we also said, when we were using the clinical reason, is it painful? Yes or no? And remember that when we start the neuro exam, physical exam, and sometimes the ortho exam should also be done in this process. So important in assessing cases with myelopathy is the neuro exam. And observation is the most important thing to do in the neuro exam, in the meaning that if you have a patient that is not cooperating, there is no point to do the hands-on. And the hands-on at this point, probably the only thing that is going to help us when we do the hands-on is to differentiate if it's a T3L3 or L4S3. And if you cannot differentiate because you cannot do the hands-on, because the dog or the cat doesn't allow you to, or it's really painful, reasons, you have many reasons, then you can say, okay, I localize T3S3 because I cannot differentiate between T3L3 or L4S3, but I know that the thoracic limbs are totally fine. And you will see that with the observation, we can have an idea, even if it's a T3L3 or even if it's an L4S3. And you can see how much important is the observation. And you can do the observation when you go and pick up the client with the patient at reception and just see the dog walk into the consulting room, or leaving the cat in the consulting room while you take the history. And then if we can, then we do the hands-on. So here, obviously, we're not going to explain all the neuro exam, but we're going to try to put it the other way around, in the meaning, what are the deficits that you expect to see when you have a dog or a cat with myelopathies? So mental status, if a dog or cat has a T3L3 or a L4S3 myelopathy, mental status should be normal. When we talk about mental status, we mean the level of consciousness. The level of consciousness is given by a normal function of the brainstem and a normal function of the forebrain. So if you have a lesion at T3L3, the dog should not be obtunded, the dog should not be having decreased level of consciousness, unless you have something that is multifocal. Posture. There are different postures that are quite specific of a myelopathy. One are quite pathognomonic. The other one is a suspicion that could be a problem with the spinal cord. Sheath-Sherrington. We're going to explain the posture of Sheath-Sherrington, and this is something that is really important to recognize. This has not been described in cats, but definitely in dogs. And if you have a dog that presents to you with a Sheath-Sherrington, there are a few things that you should make sure that you know and you recognize the posture. Then we can have desviation of the vertebral column, kyphosis, lordosis, scoliosis, that sometimes could be associated to neurology or neurological deficits. Gait, evaluating the gait. The gait can give us a lot of information, and you will see what's important when we have a T3L3 myelopathy or L4S3 myelopathy, what are the important clinical signs that we should evaluate on the gait. And ideally, you should evaluate the gait in a non-slippery floor. So kyphosis, when you have a patient that is kyphotic, it could be a sign of either thoracolumbar pain, or it could be a sign of abdominal pain. Also important that sometimes with cerebellar conditions, with cerebellar dysfunction, they have increased tone and they have some disturbance of the balance, and sometimes they are also kyphotic, but when they start walking, you see there is generally like a type of vestibulocerebellar ataxia. So it's not a ataxia just affecting the pelvic limb. So if you have a kyphosis and it's associated to really dysmetric gait, then you know that kyphosis is because of a cerebellar condition. It's nothing to do with the thoracolumbar pain. But if that is associated to a thoracolumbar pain, the dog may be walking really slowly, then you may see some paresis, like decreased motor function on the pelvic limbs, then you know that kyphosis is very likely associated to some degree of thoracolumbar pain. Spontaneous knuckling. If you see a dog with an spontaneous knuckling, that means that somewhere in that neurological pathway of the proprioceptive pathway, there is a dysfunction. And can you see the arrow? Kate, I don't know if you can say.
Yep.
Well, you have, oh, thank you. So you have the spontaneous knuckling here, yeah? And then where the problem could be. So it could be peripheral nerve, it could be ipsilateral spinal cord, it could be ipsilateral brainstem, contralateral forebrain. So in this dog, we know mental status. Well, I know because I know the dog, but the mental status was fine. You can see how strength is the thoracic pelvic, thoracic limb, sorry, and then look at the pelvic limb. So if the thoracic limbs are normal, mental status is normal, and the gait on the thoracic limbs is normal, then what we can say, just observing that this is either a problem with the peripheral nerve, a problem with L4-S3 myelopathy or a problem with T3-L3 myelopathy. You can already rule out C62, you can already rule out C1, C5, and considering that you don't have any intracranial signs, you can already rule out brainstem and forebrain. This posture. Look at this. This comes to you on lateral recumbency. You see that there is increased tone on the thoracic. You see that the mental status is fine. The posture of the cervical area is fine. And then you see there is some flaccidity on the pelvic limbs. And when they start the gait, you can see there is literally no movement on the pelvic limbs. So with that presentation, you can already say that this dog, considering the lateral recumbency, the increased tone on the thoracics, the really decreased tone on the pelvic limbs, and if they just come like that, you have to consider a Schiff-Sherrington posture really, really high on your list. And for instance, if you are on you are working as an emergency clinic, someone comes through the door and you recognize the posture, you recognize you have a dog on lateral recumbency, increased tone on the thoracics. The owner said, look, I just found him like that on the street. I don't know what happened. Until otherwise proven, that dog has a vertebral fracture, which means you don't stand up the dog and say, oh, I need to see how much movement there is on the pelvic limbs. No, because if you know that there is a Schiff-Sherrington, you know already that this is a T3L3 myelopathy. You know that there is a severe myelopathy, and you know that it has happened acutely. Severe myelopathy is associated with the degree of movement. So you have a severe myelopathy means that they are going to have no movement at all on the pelvic limbs, and that is called paraplegia, or they are going to have just very tiny movement, just a little bit on the proximal at the level of the hip. That means very severe non-ambulatory paraparesis. So you have that. That means that the only thing that you want to know is be able to feel the limbs, because that is the best prognostic indicator. And you can do that on a lateral recumbency, put it in a rigid bore. You can take some lateral x-rays. And if you know at least that there is not a big displacement on the vertebrae, it's easier to manipulate. But until otherwise proven, as we said, this has a vertebral fracture. And important to know, a dog that comes with a Schiff-Sherrington does not have any prognostic value, which means it doesn't mean that if we present with a Schiff-Sherrington, they cannot recover. It's not like that. It only tells T3L3 is acute and is severe, but it can totally recover from it. When we talk about the gait, as we said before, when we evaluate the gait, there are two systems that you have to evaluate: sensory system and motor system. So you observe the dog and say, okay, what is the sensory system? The sensory system is the one that is going to give you the coordination. Yeah, so sensory system is in charge of coordination. So what are the three systems in our body that coordinate the gait? Vestibular, cerebellar, and proprioceptive. So there are the three systems that control our gait, control that our gait is coordinated. We're not talking about the strength, that is the motor system. We're talking about coordination. So what happens if one of those systems doesn't work? Then we're going to have ataxia. We're going to have the lack of coordination. And you can see already when we talk about ataxia, and if you tell us, oh, look, Elsa, I have this dog that is ataxic, my next question is going to be, can you say what type of ataxia we're talking about? Are we talking about vestibular ataxia, that then we know is the vestibular system? Vestibular system control the balance. So you have a vestibular ataxia, your lack of coordination is because you don't get the balance. So they will be leaning and falling on all four. We don't see that on myelopathies. A cerebellar ataxia, as we said before, the cerebellum control the range of movement. So when you have a cerebellar ataxia, they are all over the place. It's really dysmetric gait. You don't see that on T3L3 myelopathy or L4S3 myelopathy. The proprioceptive system make us aware where the limbs are. So what we can see on a myelopathy T3L3 or L4S3 is that they start crossing the limbs, and that is as the proprioceptive ataxia. So if you say, oh, the dog is ataxic, it really helps us a lot if you say, oh, it's a proprioceptive ataxia, because I know that the thoracic limbs are normal, there is no balance problem, and there is not any degree of dysmetria on the gait. And that is how you describe the sensory system. What happened with the motor system? It gives us the strength, it gives us the strength on that gait. So when we have dysfunction of the motor system, then we have either paresis, which means partial loss, but there is still voluntary movement on that gait, or plegia, which means you don't have any voluntary movement on that limb. And then if we talk about partial loss, obviously we really like to know the degree of that loss, which means are they able to stand up and walk? But you see that there is either scuffing or dragging, but you see on that pelvic limbs, they are able to stand up. And that will be the ambulatory paraparetic, because depending where the limbs are affected, we talk para, both pelvic limbs, tetra, all four, hemi one side, and mono one. We don't really have a name for one that is affecting just the thoracics, but this will be how we describe the gait. So as you can see, if look at this dog, what do you think? Is definitely uncoordinated on the pelvic limbs. The thoracic look fine, the mental status is fine, and is walking on a straight line. So we can see that cerebellar is not, vestibular is not, and look, the slow motion is really crossing the limbs, but the strength is very good. So we can say that this dog has a general proprioceptive ataxia affecting the pelvic limbs. And then talking about the strength, the motor function, look at the difference. We have one that is ambulatory just with assistant, and the other one that you can see there is a little bit of movement, but is not able to stand up. So how we describe those gaits, and again, it really helps us when we want to discuss a case, if we talk, okay, is ambulatory with assistant, is paraparetic, or is non-ambulatory paraparetic. And then if we talk about only one limb, again, we can say, okay, this is a little bit of movement on the left side of your screen, so we call it monoparesis, and there is no movement at all on the right pelvic on the left pelvic limb of the boxer, so we call it monoplegia. And if you just look at this image, you can say, okay, this is either a T3L3, very lateralized on the husky on the right side, L4S3, really lateralized on the right side, or a peripheral problem really just on the right side. And you haven't touched the dog, and you already can kind of narrow that list of differentials. On the gait, sometimes we have really controversial. Look at this. It's definitely not well coordinated on the pelvic limb, but look what he's doing is really tiptoe. Yeah, he doesn't really want to put too much weight on the pelvic limbs. And what do you think about? Doesn't really sound neurological, no? Doesn't sound as we have described. These are no signs of paresis, and the coordination. He was not really crossing. Was really trying to walk on the tiptoes, and this dog had a bilateral cruciate. So this is not neurological. And I just show you a case that it was a challenging case for us. So look, this is a 4-year-old border collie that presented, the history is really chronic. So we have 6-month history of what the vet said it was off the back legs, but it's episodic and sometimes show a non-bearing lameness on the right, and it was really painful. So typically we saw the dog, it was totally normal, but while the dog was in the hospital waiting for imaging to happen at the lumbar sacral, because one of our differential was, okay, has pain, but it goes off the back legs. It could be nervous signature that is really painful. So the dog had an episode while it was in the hospital, and we understood what the owner was saying. You can see how, and these dogs are really clever. It was like, I knew it was able to walk on the thoracic, but he was so painful that he really didn't want to walk in the corridor. And sometimes it's hard for us to say what is true, how much is just him that doesn't want to walk. So I said, okay, let's go. And he was really painful, say, okay, let's go close to the kennel that he was at, and he may be going there because he knows he's gonna be no bother at all where in the kennel. So we just to him. I just wanted him to go into his kennel, and you can see how now he say, okay, I think I'm gonna relative safe place. I'm not in the middle of the corridor, surrounded by students. And you can see how I saw the kennel and was not so keen at the beginning. I say, okay, I can go. And can you see, this is the real gait. It was not really putting weight on the right pelvic limb. This is the slow motion, and it was really painful, poor little puppy. So we say, okay, it could be lumbar sacral, it could be pain. And then we went for MRI, and yeah, it was really subtle. It had a lumbar sacral stenosis and definitely a little bit more on the right. I'm just going to point here. This is a sagittal T2 weighted image. This is the sacrum. This is L7. And we can say, yeah, probably this is a little bit narrow, but it was so painful that I say, okay, let's see if there is some, because MRI is really good for soft tissue, but sometimes it's not so good to see tiny bone lesions or evaluate the foramen. So we complement sometimes with a CT. So we went for the CT, and then the radiographer called me and say, "Oh, I just put the hip back. It was luxated." I said, "What do you mean?" I said, "Yeah, it was luxated. So when I placed the dog on CT, I just noted that I put the hip back." I was like, "What are you talking about?" So I went back to look at the MRI, and look at that. Before we did the MRI, you look like a scanner, and the hip was totally out of place. So we did some X-rays, and it was really easy to subluxate, and it's not really common, but it was a ventral luxation of the right coxofemoral joint. So every time you luxate, it overstrated the nerves, and it's really painful. And then what probably was doing the dog with some movement, it was putting it back to normal. So what we did in this dog was a working dog, so it was really crazy jumping. So we did a strict rest and some of these real gobble system, and the dog did extremely well. He's back and running after. We did pretty good 4 to 6 months, because that allows the fibrosis of the capsule at the level of the hip to form. But this was the case of, yes, it's off the back legs, but it's not so easy, yeah. And then going to the hands-on, I'm going to do this a little bit because, as we said, it's important that we recognize the clinical signs on the observation. But when we do our hands-on, the first thing probably that we will try to do, I don't mind the order, but sometimes what you do first is the postural reactions. And you have to remember that this is a conscious perception. So if either the dog is sedated, if the dog is waking up from anesthesia, if the dog is extremely scared, sometimes they don't want to do it, rather that they cannot do it. Spinal reflexes, the muscle mass and the tone is going to really help us to differentiate if we're talking about a T3L3 or a L4S3, because if we have an L4S3, the spinal reflexes will be decreased to absent, the muscle tone will also be decreased to absent. And then the cranial nerves, in this case, they should be normal. And the palpation to see if there is any area of pain. This is the only thing that I will recommend to do it at the last. So testing nociception, in general, it should only be done in limbs that are plegic. What I mean, if a dog can have a voluntary movement, and remember that a reflex is not a voluntary movement. Voluntary movement means that the information is getting to the contralateral forebrain and is initiating the movement. If you see that type of movement, you don't have to do nociception. As a general rule, when you have an acute myelopathy or chronic myelopathy, dogs will lose first the motor function, and the last part that is lost is the nociception, because sometimes they are so painful and you say, oh, it doesn't have any pain, but probably so painful that the last thing he cares about is someone really pinching the toes. So as we said, remember that the postural reactions is a conscious perception. So look, if we put the foot in an abnormal position, as you can see here, so we put the toes in a normal position, that information is detected by the receptors, the peripheral nerves. It goes ipsilateral spinal cord, ipsilateral brainstem, contralateral forebrain, and then you say, oh, what are you doing? And the motor function from the contralateral forebrain has to reach the brainstem, spinal cord, peripheral nerve, and put it back to normal. Yeah. So as we said, look, this is my own dog, and this is doing the postural reactions. And I tell her, stop, don't move, don't move. Can you see? And she has deficits. And then I tell her, put it back to normal. Yeah. So if that was a reflex, you cannot do that because that will happen anyway. So the only thing I want to tell you is that that's a conscious perception. So they should be aware of it. And if there is something that interfere, they may have it affected. We can test postural reactions with doing the hopping, doing the tactile on the table. So there are different tests to evaluate these pathways. But hopping is also helping. That information also go to the cerebellum, but sometimes with the cat, you do the hopping and they don't want to put the limbs on the floor. So sometimes we have to try to combine the different tests to evaluate the same pathway. So as a general rule, the postural reaction will be decreased to absent caudal to the lesion, which means if I have a T3L3 myelopathy or L4S3 myelopathy, the postural reaction will be absent on both pelvic limbs. It will be present in the thoracic. If it's just unilateral, it will be absent just on one side. So how can I differentiate? As we said before, doing the spinal reflexes. The most reliable reflex that you can do, and if you're in general practice, this is the one that is going to give you the majority of the information, is the withdrawal. But it's important that you fully extend the limb and then you allow the patient to flex all the joints. First, you want to check that the dog doesn't have any joint problem or any anything mechanical that will stop you to do the reflex. But if they can do that, then the withdrawal reflex is the most reliable one. From the cutaneous trunci is a reflex. And I just want to show you this one because if you have a dog with a severe myelopathy, that is something that is important to monitor. When we do the cutaneous trunci, it means that we pinch the skin, and then when we pinch the skin, that information travels more or less to vertebrals, crania, to vertebral crania to it, enter the spinal cord, and then exit through the thoracic to the lateral thoracic nerve at the level of C81 and meant the contraction of the cutaneous trunci. So imagine if I have a lesion here, call it at the level of T13L1 vertebra, what happened? I pinch here, look, is blocked. I'm not going to have the reflex. So I go a little bit cranial, is blocked. I go a little bit cranial, and then yes, I have the reflex. So then you can say, okay, I have a cutoff pretty much at the level of T13. And that help us in which way, for instance, to localize narrower between T3 and L3. And overall, if you have cases where we know that condition can cause what is known myelomalacia. Myelomalacia means that the spinal cord get necrotic and they can extend, ascend and descend, and this is a very bad condition to the point that the dogs that suffer that, they have to be euthanized because they start having difficulty breathing. So imagine if you have a cutaneous trunci cutoff, and this is a pelagic dachshund that presented with a severe T3L3 myelopathy, had an intervertebral disc extrusion at the level of L1, L2, where we did surgery, but the spinal cord looked very bad. And this was paraplegia with absent nociception, which is the worst spinal cord or severity of the spinal cord that we can have. And this we mark when the cutaneous trunci cutoff is there. So in this case was at the level of L3, L4, pretty much 2 vertebrae caudal to the lesion. And look, within a few days, the cutaneous trunci cutoff moves cranially, which means the condition is extended, which means it's a clinical sign of progressive myelomalacia, which means that dog is never going to recover and is going to start difficulty breathing, and you don't want that to happen. I'm going to show you a clinical case just because, this is it moved cranially. It's important to recognize if you want to do the hands-on. For instance, this is a dog that presented with peracute onset of monoplegia. Can you see it's not able to move at all the right pelvic limb? We do the spinal reflexes on the left pelvic limb. They were totally normal. They were withdrawal on the pelvic limb, totally normal. But look at the tone on the right pelvic limb. The tone is totally gone. The patellar is not really good. And then when we do the withdrawal, you can see that it's also severely affected to the point that it's considered absent. But the nociception, you can see at the same time that you text the reflex, you can say any conscious perception to that painful stimulus. And then we can see that there is some cutoff, so that is at the level of L2. So we have to put everything together. You can say, okay, if you believe the cutaneous truncae cutoff is probably a myelopathy T3, L3, but if we believe the spinal cord segments, the spinal reflexes, it seems that it's a L4, S3 myelopathy. But with acute myelopathies, there is a condition that is called spinal shock, which means that if you have a lesion, for instance, T3, L3, for a period of time that is usually less than 2 days, all the neurons caudal to the lesion are hyperpolarized. And if you have a neuron that is hyperpolarized, they cannot, you cannot elicit any spinal reflexes. So you have decreased spinal reflexes, but that is just temporary. And as I said, the last thing that we do is to check if there is any pain, because remember that the spinal cord doesn't have receptor for pain. And as a general, as I said, the last thing that we test is the nociception. So look at this dog. This dog has reflex, but it's not turning to my painful stimulus. And you say, oh, it's very good, it's so nice, doesn't want to say anything. You can gently touch one of the limbs that you know it feels. And this is what it tells us, that there is a severe condition affecting the spinal cord. And then let's put some clinical reasoning. And I'm just going to do a couple of cases. So as Kate said, if you have any question, you can start writing that in the chat. But what I wanted to just make a summary, because when we talk about an intervertebral disc disease, and I would avoid using that terminology because probably is one of the conditions that we will see the most with spinal cord diseases, it's important that we specify that our suspicion is an intervertebral disc herniation. And remember that when we talk about intervertebral disc disease, we have degenerated disc and non-degenerated disc. So the nucleus pulposus, which is this part of the disc, usually is, if it's non-degenerate, is really hydrated, is really like water. So, but if they degenerate because either the breed, chondrodystrophic, French bulldog, dachshunds, the nucleus pulposus becomes really hard, and sometimes that can come out of the place, and that is called extrusion Hansen type 1. Sometimes it's the dorsal part of the annulus fibrosus, which is the surrounding part, that becomes thicker and thicker and thicker, and that is called protrusions. And these are the only two degenerated discs. Then if the amount of, or the type of material that comes out is non-degenerated, what we have to think is that it's usually really like watery, and that type of disc, either when a small amount comes out, hit the core, but it's not really compressing, that is called acute non-compressive nucleus pulposus extrusion, or when the amount of the compression is significant, but is really hydrated, that is called hydrated nucleus pulposus extrusion, or when a little piece of that hydrated material goes through the core, and that is called intramedullary disc extrusion. So these are the type of discs that we're going to just see with acute myelopathy. And talking about the differentials, and you will have this recorded, so I just don't want to rush too much, but I want to do one case and then we are done. But it's important to use the clinical reason, and we make some explanation. For instance, you have something that is acute, is progressive, and is not really lateralizing, and is really painful, then what are the most likely differentials? So an intervertebral disc extrusion, Hansen type 1, inflammatory infectious, or something like a trauma. What happens is non-painful, then we can have this hydrated nucleus pulposus extrusion because it's really hydrated. It's not like this degenerative material compressing the spinal cord. Inflammatory infectious, neoplasia. What happens if you have something that is acute progressive lateralizing? Pretty similar. But for instance, what happens if you have something that is acute, is improving, is lateralizing, and is painful? It could be still something that is non-compressing the spinal cord, but at the beginning can be some painful, or a trauma really lateralized. But if we're talking about something that is extremely lateralized, non-painful, and is getting better, to be honest, there are only two things that can cause that. Either we have an ischemic myelopathy, or we have an acute non-compressive nucleus pulposus extrusion. And then if we have something that is chronic, then we're talking about something more inflammatory, infectious, really a degenerative protrusion intervertebral disc, neoplasia, inflammatory, less likely, but still possible. So again, just a few list of differential diagnoses that are the most likely having that clinical presentation. So let's look one case and then we can stop here. So this is a bull mastiff, if 4 years old, male nurtured, that presented with acute onset of, well, how would we define that? Look, it has decreased motor function on the left pelvic limb, but there is motor function. So we call it monoparesis. But look at the tone, it's really good tone. And it presented peracute after playing in the garden. It kind of yelped suddenly and it became like that. And you can see the right pelvic limb is pretty much normal. And the left is severely affected because he's really not able to stand up on that limb. No, it's really kind of severe paresis. Has patellar, but look, when we do the withdrawal, it doesn't have a good withdrawal, but the tone is really good, which it doesn't fit with lower motor neuron, correct? Because that will be like really decreased muscle tone. So, and the dog was not really painful at all. So when we talk about the localization, either could be a T3L3, we rely on the tone because it's really good, or it could be L4S3, we rely on the sciatic. But as we said, just the sciatic, it will not cause such a severe paresis. So the most likely is that we may be talking about a T3L3 with a spinal shock, as we talked before. But we have something that is acute, is definitely not getting worse. It just happened like 4 or 5 hours ago, and it's not painful, and it's extremely lateralized. So there are very few things that can do that. And as we said, it could be an ischemic myelopathy or an acute non-compressive nucleus pulposus extrusion. What are the different? What could we do if we have those two differentials? As we said before, if we have this type of intervertebral disc where we have just a small amount that comes out, is really hydrated, makes a contusion to the core, then we just do rest. We used to say strict rest, gait rest. We don't do that anymore. I say gait rest, and this is why they build up in the living room. We just want to avoid impact exercise because you want that fibrotic tissue of the annulus fibrosus to heal properly. So we just do a lot of physiotherapy and avoid impact exercise. And then the other differentials in this patient, it could be an ischemic myelopathy. An ischemic myelopathy, usually the vascularization in the spinal cord sometimes go to the right, sometimes go to the left, and means that one of the area got an ischemia, but the dog is moving the limb. So physio, and then try to look the underlying cause. But in the majority of the dogs, we don't find an underlying cause. Look at this dog the following day. It's definitely much better. We cannot get to the final diagnosis, but these two diagnoses are the most likely. You have this peracute onset, really lateralized, and at least not deteriorating at the time of the onset, and a few hours later, the dog is either the same or a little bit better. And look at the dog 48 hours better, so it's definitely much, much better. And if you have any question, I will be more than happy to answer. I just wanted to put a clinical case so we can apply that into practice.
Thank you very much for that, Elsa. That was fabulous as always. If anyone does have any questions, please feel free to pop those in the chat. I'll start off. Obviously, you give lots of advice. You see lots of patients coming in through your clinical areas, and we know that neurology can seem confusing to people. So what are the things you see where people have got confused? What are your top tips to try and help people to get less confused with these dogs that have issues with their back legs? Is it what you said, like just watch them, don't worry so much about the hands-on?
Yeah, I think totally. I think it's just avoid to consider neurophobia and just step back. Okay, let's just gonna observe from the distance. Yes, it can look quite stressful that suddenly you have a dog that comes, and sometimes it's also the owner that comes super stressed because the dog suddenly cannot use one limb. But then, okay, let's go back. It's not using only one limb, but the other one is working. Okay, so we can say that definitely is something that is not really compressing the spinal cord, because if it was really compressing the spinal cord, the contralateral limb should be working. So before, it's true that dogs that comes off the back legs as a clinical presentation can look quite stressful, but this is why I start the lecture using the clinical reasoning, try to get all the history, and then try to narrow our list of differentials, because it doesn't mean that all the dogs with the back of the back legs have a bad prognosis. The most important is, and again, we're here to help also from the telemedicine point of view. And for us, what is really important is also watching the videos, because observing, as you can see, for us as a neurologist, we can really help a lot on the localization, and then discussing the history, we can really get to the point that we can narrow our list of differentials and try to discuss cases that may not be able to be referred. And that doesn't mean, okay, looking at the history, looking at the degree of lateralization, looking at the fact that it's painful. So even a focal meningomyelitis could be one of the differentials. And then depending where the region the dog is, likely to be immunomediated, likely to be infectious. So I can totally understand that sometimes can look scary, but as I said, using the clinical reasoning, discussing with the knowledge with a neurologist, as we said here in VET.CT, and the clinical experience, it can really make the approach to that case less stressful.
Brilliant. Apparently the chat function is disabled, so please use the Q&A for any questions rather than the chat if anyone's got
Thank
them.
you, Belinda.
So I guess some of the sort of challenges I've had over the years, and you had some big dogs there, is the sort of 60, 70 kilo dog that comes in that's not able to stand. And I guess the other just observation, that collie was a brilliant one to show the hands-off approach and getting it somewhere more comfortable. So when you've got a really big dog that you can't actually get to stand up, how do you compromise that on your gait and your observations?
Well, I guess if you cannot stand up, then you can call it already non-ambulatory. Now the question is that, is it neurological or not? And if you see a little bit of movement and you don't have any orthopedic, because if you have a dog that is not able to stand up and has an orthopedic condition, it should be quite obvious. And that was obviously it's nothing to laugh about it, but I remember that we had a dog referred to neurology because he was or it was reported to be paraplegic after a road traffic accident, and he had bilateral femur fracture. So I think, again, depending on the history, what is of the back legs happen acutely, does it have any trauma, then definitely it could be something orthopedic about it. Or if it's neurological and you cannot really stand up, you already know it's not in non-ambulatory. Can he move it a little bit? Then he goes into the category of being non-ambulatory paraparetic. And if he's a good boy and we can do the spinal reflexes on lateral recumbency, that can help us to neuro-localize. And then the list of differentials, it happened peracute, then it could be an easy painful, then it happened peracute and is painful, it could be an intervertebral disc herniation, it could be a trauma, it could be even a vascular that is compressing the meninges. So there are different differentials that we can do.
Great. So I've got a question. When you're doing proprioception, is it necessary to support the weight, and
Yes.
how you do that with the really big dogs?
That's it. Well, with really big dogs, you don't have to hold the weight, because what they have to do, they have to feel that this is touching the ground, but they don't have to have all the weight on the ground, because then it's the weight that makes them to kind of respond. So it's a balance between just a little bit. You don't have to hold the weight. So being a big dog or small dog doesn't really change at all. If it's a big dog, you just go on the back and you just put your hand at the level between the legs and just do it a little bit. And then you stand on the front and you put your hands at the level of the sternum, because then you have the elbow in the face, so that will not go to you if for whatever reason the dog goes to you. and then just hold it a little bit. So this is the only thing when it's a big dog that you have to do it. And obviously you have the Great Dane that is even you cannot do it. So you just hold a little bit from behind on the sternum. But it's a balance to just hold it a little bit versus hold it a lot. Sometimes you see that they do the proprioception without holding the weight at all. And that's not correct either, because then just the weight of falling, they can feel it rather than just a tiny touch, just holding a little bit the balance. So sorry, the weight. So it's kind of a little bit of an average, no, not too much, not too little.
Excellent. Well, we will hopefully fairly soon have a video that we'll have on our website to help you with your neurological exams. And as Elsa said, videoing the gait, videoing you doing your neuro exam is really, really helpful to share when you're looking for advice through the teleconsulting service, because the videos do say more than many words. That can really be the clarity point, can't it, Elsa, on some of these cases. Correct, that yeah. we see. Brilliant. We've answered the questions that have come in live. If people have more questions, I'm sure Elsa will be happy to answer those for us afterwards. So you can send those in and we can put those to our neuro team. But it just remains for me to thank Elsa for a fabulous presentation, and you guys for attending this evening, and anyone who's coming in to watch on replay. So thank you very much, and good night.